Hello, welcome back to the Lance, where we do what we can't rely on the Lancet to do, which is to take a more skeptical view of the medical establishment. Today, I thought I would share with you footage of a debate on Cauda equina syndrome, which took place recently at a national spinal conference in Glasgow. Cauda equina syndrome is a rare but potentially catastrophic condition where the nerve roots at the base of the spine are suddenly critically compressed, and it can render you incontinent of bladder and bowel, prevent your normal sexual activities, and leave you with weak, numb legs. It was decided some time ago by somebody that a pathway might improve care for patients who are unfortunate enough to suffer from this condition. The pathway was published and, as you will see, subsequently debated. And I thought you might be interested to see that nothing in medicine is ever that black and white, and there is always a lot of grey. So I hope you find the following recording of interest.
Ladies and gentlemen, now the gloves are off. We're going to have a gentlemanly discussion about Cauda equina syndrome. And we have to start the proceedings with a vote, and then we'll finish them with a vote. Because the debate is going to be the motion that this House believes that the GIRFT pathway for the National Cauda equina syndrome pathway is the best way to improve patient care and reduce litigation in the NHS. All got that? GIRFT pathway is the best way to improve patient care and reduce litigation in the NHS. And supporting the motion is Mike Hutton. Quite rightly, he's spent so much time developing the GIRFT pathways. And opposing the pathway is Tim German, who always has an opinion.
Which is usually wrong.
Which you may not agree with. So let's start with a vote from everyone. It's just going to be hands in the air, and I'm going to be the adjudicator. So if my maths isn't very good, that's tough. So I'd like you, those of you who believe that the GIRFT pathway leads to an improvement in patient care and a reduction in litigation, could you stick your hand in the air, please?
See, I'm stuffed now.
The only way is down. Okay, that's a good start. I counted all of them. And so we'll go on. The person who's going to propose the motion is Mike. So please, Mike, he's got 15 minutes to support the motion.
Yeah, so thanks very much, Britspine. Thanks very much, Patrick. Thank you very much, Tim. And I'm sorry about what I'm going to tell you, Tim. So I apologise now at the very beginning. So, yeah, look, I mean, of course I'm going to argue for this. It's been the toughest thing I think I've ever had to do in my career. What I'm going to start off is go, well, look, why do this? I know that in this pathway there will be bits of it that people disagree with. And I love this. For every expert, there's an equal and opposite expert in terms of opinion. So this is not about trying to persuade you your opinions, etc., that might be set, but it's about the motion. And the motion is that this, I think, will improve patient care for patients with suspected Cauda equina syndrome and also reduce litigation. So, what is the case for standardised pathways? Tim, do you like pathways? Do you like guidance?
We'll come to that.
Oh, we'll come to that, okay. Well, I mean, it's really interesting how views may change. But if you go back, we had this document in December 28. It's a really good document, actually. Standards of Care for Investigation and Management of Cauda equina Syndrome. Badged by BAS and badged by the SBNS. and Tim was in charge of it. So I would suggest that you do believe in pathways and guidance, and it was a good document. Now, the thing is we are talking about something that, if you look on the internet, you know, what is Cauda equina syndrome, you'll get 156,000 results. And so a starting point is actually, what are we talking about? And that is just, that in its own right is a point we could discuss for hours on end. So the pathway set to build on the work that had been undertaken by what is now the National Spine Network with NICE, etc., and made some changes that were as a result and reflection of what that pathway ended up causing in some ways. And that was that if you go round, and I have been round every unit in the country, some of the units were crying in pain, and the emergency departments, because patients who had had symptoms related to their cauda equina function that had been static for months were being sent up to the emergency department. So that was contentious. Let me tell you about other contentious things that went on. Okay, we just even had to define the incidence, all right, and that was difficult enough because we had patient groups involved with it, more about that in a bit, and just saying it was very rare, which it is, 1 to 3 in 100,000 is very rare, you know, that is the incidence of motor neuron disease. This is a very rare condition, and we also had the latest data to sort of confirm that. So there's lots of contentious bits in it, and that was debated for ages. So what else do we know? We knew this, okay? So the evaluation and treatment of investigation of cauda equina. This came out not long after Tim's guidance, and it showed what I suspect everyone in the room knows, is that the referrer for this condition was usually outside the neurosurgical centre, okay? So that was the number one referrer in, and then there was GPs. And at that time, 73% was outside the unit. 64% of those cases were made without an MRI. Tim's guidance tried to deal with that. And of that, 16% of people did not actually require an emergency MRI. So this is some of the data of what day of the week. It always amuses me that this emergency condition seems to happen less on Saturdays and Sundays. You can work out from that what it's about. And also, here's to show you that it doesn't just occur uniformly during the day. Referrals are made through the night and in the middle of the night. And if you take the patients who were transferred for an emergency MRI scan and no surgery was performed because the MRI was negative, then that patient's average length of stay was about a day. And it's really clear in the GIRF data that if you ran a cauda equina surgical service, it impacted on your elective activity. So in our report, in the Getting Reverse Time, we identified the problems again that everyone knew about. The scanner was on, your scanner is on, you know, cost of living crisis, it's still on because it has to be air conditioned. The main problem appeared to be out of hours radiographer support. And it was quite clear to me that all the emergency services were quite happy to look at an MR with someone with symptoms without the radiologist report. But if I made a big mistake, and this was one of my biggest mistakes, was I spent the last 2 or 3 days before the report came out, you know, on the phone to the President College of Radiologists, talking about deliverability, how they hadn't been involved and it wasn't collaborative. So, litigation. This is the litigation data across England. If you look at why is there another, that's the ambulance service, or partly. Please don't read it that, you know, Northwest England, because these are very different geographical population sizes. But what it does allow you to see is there is variation, and there's lots of reasons for it, but about £120 million was spent on our estimations for not cauda equina, but the delay in the diagnosis to it. So that was really powerful stuff. And if you want to see the sort of thing that we ticked as being, it's at the bottom left, example of data, failed to diagnose and treat cauda equina, failed to suspect cauda, failed to arrange an MRI. That's what we meant by delay in diagnosis. So we know we've got a litigation problem. So as if by magic, on the day the pathway was released, here was a man, and this is another reason why we needed a pathway, who was sent up by his GP on the day he presented the GP with a very short history of severe pain into both of his legs, with altered sensibility and weakness in his legs, where he had numb genitals, and it felt odd when he was urinating. This was his emergency MRI, which showed confirmed cauda equina compression. And he had a bladder scan which showed he could void. Okay, so what was his advice? From the neurosurgical department trainees who saw him, as you're emptying your bladder, surgery is not required. you'll get better. Okay? So anyone who thinks we don't need a pathway, we need a pathway. So here is the pathway, and this is another next. This is the difference, I think, because the pathway is end to end. You know, I put it to the surgeons in the room. Do you know what you should be saying to the patient who you've operated on with Cauda equina syndrome, and they come back with all their symptoms, and you go, well, you know, yeah, there's nothing more I can do. We've rescanned, there's nothing. But I'll send you now onto the Cauda equina rehab centre, spinal cord injury centre, where it's going to take you 6 months to get there. You can start that process. And so we had everyone we could possibly think of, and every society that was involved in the management and care of these patients, and came up with the pathway. When you go onto the interactive pathway, you just click on that big button, it takes you into this. And what was also neat is that we highlighted, had heads up, that there was actually a National Clinical Imaging Board that was writing a document on MRI provision for Cauda equina syndrome. So guess what? We don't want to have two opposing documents coming out. We work together. And they came out on the same day. So we had all these groups. But if you want to know, it's me versus Tim. It's not me versus Tim. It's Tim versus all these people that were involved, okay? Okay, so how does the pathway work? When you go into it, if you click on any of those coloured boxes, it will go into finer detail on them. And you can go into the pathway where it represents you. So the advice on surgery is there. If you're working in primary care, it gives you the right place to go. It gets some clarity with some of the people who wrote the papers about what they meant on them. The front end of the pathway, the contentious bit, the 2 weeks. Why 2 weeks? Well, we can discuss that in the discussion. But it highlighted the symptoms that we thought were relevant. Why do a bladder scan? What are you actually looking for? So these were this is not massively new work. It was the 2 weeks bit. So I am highlighting stuff. But the other thing is everyone gets, safety net the patient. What does that mean? What if they're from the Ukraine? Well, on there, you click on that. It gives you the Ukrainian translation card, okay, to give to the patient about, you know, these are the things to look out for if you have just presented me with sciatica, etc. So it's all on there. Bladder scan. It became quite apparent in the group that we all thought bladder scan was a great adjunct, and as Mike Gravett said, it is 20 times more likely on a scan that you'll have Cauda equina syndrome, Cauda equina compression, if you're post-residual volume. But the confusion, as you saw from the earlier case, was quite apparent. So it's an adjunct. We think it's a great thing. We might even be able to use it in the future when we get better data. Imaging, that was the big one for me. We have agreement with the Royal College of Radiologists, okay, and the radiographers. They're really up for this, okay, that we should be doing a scan. If we think someone's got this condition, as soon as possible, and certainly within 4 hours. Where does the 4 hours go? Well, we all recognise that. We just know it's a target. There were people who wanted it straight away, and there were some reasonable discussions as to why that could or couldn't happen. But also, all the stuff that the radiologists wanted us to have in there, like the safety checks, you know, what they felt about reporting, etc. So they're on board with this. And they realise we're never going to get the problem solved unless we actually set standards that we've got to adhere to. So also, what do you do when they don't have lumbar spinal canal stenosis of their Cauda equina? Oh, sorry, you don't have Cauda equina compression. Well, this is what the radiologists want us to do, okay? How many times have you had the patient back and you then see them and say, there's nothing right there, we've got to scan them up higher? And they showed us how they think we should develop services in places that haven't happened. And I totally get this takes resource, and we need to drive this resource. But without the document, I've been there locally, trying to change things in your own hospital, when you know what the right thing to do is, doesn't get listened to. When you've got a national document saying, look how powerful this is, collaboratively, it will help drive change. Okay? We talk about surgery. Great example. I'm not catheterizing these patients. I don't need to. They don't lose much blood loss. And the urologist went, what? Really? You might be causing the problem because they've sat there, their bladder's not quite working properly, and then it's blown up, and there's something called blown bladder syndrome or bladder distension injury that we may be causing by not doing that. So again, the collaboration bit was important. And also importantly, there was the concept of a new consent form. We can work on all of this. We can make it all better if we don't think it works. But this is what you do if the patient is in front of you. Lots of these patients need psychological support. All the groups, the Cauda equina Champion, Spinal, they have resource, and it's somewhere you can direct your patient to. So I think it's a fantastic thing. But all of that, really importantly, Really simple concept. If you have better patient care, you reduce litigation. That's what litigation is about. And if we have all sorts of different opinions, as we've said at the very beginning, then we'll always have litigation. So I'll finish on this, okay? Which is, you know, I can't foretell the future. But the simple fact is I do believe having some structure and rigor will stop problems like we saw in the case earlier on. And quite frankly, I do think it will improve patient care. But we will try and do it. So I'd like you to vote for the motion, even though most of you have already. And lastly, I'd say thank you very much for inviting us to talk about it. It's been really good. Cheers.
Thanks very much, Mike, and thanks for sticking to time. Come and have a seat, and we'll see if Tim can argue that black is white. Over to you, Tim.
Thank you very much. Mr. Chairman, ladies and gentlemen, I'm actually grateful for the honour of being asked to speak against this motion. And I was approached at pretty short notice to be an antagonist in this debate by colleagues who were concerned that the pathway hadn't been sufficiently evidence-based and not been adequately scrutinised. And I'm not an expert in this by any means, but colleagues were aware of my general position when it comes to guidelines, pathways, and other edicts from above. And that is that they are generally created when there's a paucity of knowledge. So they represent an attempt to create certainty where there really isn't certainty, and quite often they just end up being another version of the emperor's new clothes. So when I was asked if I would entertain doing this, I didn't really know anything about it, and this is about a month ago, but I was happy to take on the challenge, even though I thought it was a bit of a poisoned chalice. And I was happy to do it to really see if my default position might be justified in this case. And actually, you know, I've learned an awful lot from doing it, and it's been an interesting exercise. And maybe some of what I've learned I can inform you of, and you may have a different opinion at the end of this. Anyway, for those of you who don't know, I come from Plymouth, which is down there in the far southwest of England. It's about as far from Glasgow as you can get and still be in the UK. And Mike comes from just up the road in Exeter. And we've had many debates over the years. But Exeter and Plymouth are very different cities. They've got very different characters and they've got very different histories. For example, in the English Civil War, Exeter was a royalist stronghold, Plymouth was a parliamentary stronghold. So I think it's entirely appropriate that in this debate, Mike is representing the establishment with orders from on high, whereas I represent the more anti-establishment view. Now, irreversible CES is an unmitigated disaster for the individuals concerned. And it is also responsible for expensive negligence claims. But claiming this pathway will improve outcomes and reduce litigation assumes we know the reasons for poor outcomes and litigation claims, and that a pathway will address these problems. And none of this is actually true. According to the proposals, more rapid access to surgery is a key issue. However, in a recent observational study of UK practice, which I will refer to frequently as the Edinburgh study, of 621 people undergoing surgery for Cauda equina syndrome, 99% had surgery within 1 day of admission and 90% within 1 day of referral. Now, for a condition which can be difficult to diagnose, has a very variable natural history, which we don't fully understand, this suggests that current management is actually pretty good, although data relating to pre-hospital care is much harder to understand. Litigation claims tell us nothing about what actually happened to individual patients, and they are a very distant surrogate for measuring standards of care. So, from my perspective, it isn't really clear what the pathway is supposed to be addressing. Now, accepting that there's always room for improvement, it seems reasonable to assume that any attempt to improve management should be based on an understanding of the natural history of the condition, and that deficits in our knowledge are also recognized so that we can both be honest with patients and we can look at areas which need further research. I mean, even the diagnosis, the definition of CES is not easy. As you can see here, there are at least 17. So the hallmark, though, is the inability to voluntarily void the bladder with overflowing continence, which is a consequence of losing your parasympathetically mediated relaxation of the sphincter. This is almost always associated with back pain, leg pain, and perineal numbness, but this probably represents a really late stage. And what we really want to do is identify people who have early symptoms and are at risk of inevitable progression before it becomes inevitable. So the cause of neural dysfunction in Cauda equina syndrome is ischemia. And both human and animal studies have shown that the most important determinant of whether neurological dysfunction occurs is the pressure at the site of the compression. If the pressure exceeds mean arterial pressure, there is a very high risk of dysfunction and irreversibility. Duration of compression is less important, but if you have pressure above mean arterial pressure for more than an hour, then irreversible neurological dysfunction is almost inevitable. So the plot you can see is of loss of function on the vertical axis, so the higher up you go, the worse it is, against the product of pressure and the duration of pressure. And you can see that it's a sigmoid shape, which is important. It's likely that the rate of compression is also an important variable. It's a common observation in neurosurgery that neural structures can continue to function despite being severely compressed if that compression has evolved over a long period of time. On the other hand, if you have a sudden major compressive force, it could cause irreversible harm very quickly. Hence, dealing with acute compression from a disc prolapse is a very different kettle of fish to dealing with chronic compression from facet joint hypertrophy or spondylolisthesis. And these are the sort of things that you might hope are addressed in any pathway. The problem, most of the time, is that an acute disc prolapse may cause people to go from minimal symptoms, so the bottom left, to maximal signs, top right, very quickly. So they're going from the bottom left of the graph to the top right in a very short time. And the question is, how do we prevent that? Now, disc prolapse is a common problem, and we know that most people will make a complete recovery without surgical intervention. They will stay in the bottom left-hand part of that chart. Somehow we have to identify the people in that area who we think have a risk of progression which is greater than the risk of a significant surgical complication. And actually, that is much greater than I'd appreciated before I investigated this. The risk of a complication is considerable. Gerft's own data states that the complication rates for CES decompressive surgery are 6 times higher than decompression for non-CES conditions. The Edinburgh study reveals a 12% dural tear rate and neurological worsening in 12%. It's enormous. In the Edinburgh study, in only 28% of cases was the primary surgeon a consultant, and in 59% of patients who were operated upon, they had an interspinous approach. So, could it be that inexperienced surgeons and unsafe surgical practices are actually responsible for poor outcomes? The situation is further complicated by the absence of a radiological definition of significant cauda equina compression. If there is CSF visible around the nerve roots on the MRI scan, the pressure is not great enough to have displaced CSF, and so the nerve roots are not under pressure. Despite this, most, if not all, studies include people who have been diagnosed with clinical CES, but they do not have radiological CES. In the Edinburgh study, only 47% had no visible CSF on axial images. Presumably, they didn't have CES because of nerve root compression, but inclusion of these patients will inevitably distort the results. So the absence of a radiological diagnostic criteria or something else is something else that we might think guidance might address. So, having identified areas for management which might be important in decision making for individual patients, it's important that a pathway should include these individual factors. And then the question is a pathway the best way to affect any change that you think needs changing? Now, the Romans knew how to build efficient pathways. This is the Foss Way, a direct route from Exeter to Lincoln. And you just have to add some ancient Greek ideas to this, and you come up with a pretty good pathway which is likely to be effective. So, the patient has a problem, they see someone trained in making a diagnosis, a few tests are requested, and once the diagnosis is confirmed, you have a discussion about potential risks and benefits of intervention. If you need further help, you can either consult a colleague or refer to something like this, which is called a textbook. And this is a very different pathway to the proposed pathway, which I would say is a bit more like spaghetti junction. So it's not at all clear how this is supposed to be helpful or to who. Most of the pathways in steps which are, I think, to me, largely pointless. I mean, is it really helpful to state that there should be an assessment and documentation by the surgical team and that the details should be added to the BSR? It doesn't offer any advice on important issues I've highlighted. In the two sections on pre-hospital care, CES symptoms are considered and bilateral radicular pain is considered a high-risk symptom. There's no evidence provided to tell us how important this is. It seems unlikely that it's very specific because 25% of elective decompressions are for bilateral sciatica. A tiny, tiny proportion of those will have cauda equina syndrome. There's a reference to the arbitrary 2-week time frame, which Mike's already mentioned. There's no reference to diagnostic radiological criteria or the difference between acute disc prolapse and chronic compression. Bladder scans are mentioned, which is good. It mentions consent, but it doesn't give advice that 12% of people will be worse off following surgery and 12% will have a dural tear. The pathway does not advise on surgical approaches, but related girth advice suggests that all approaches are reasonable. There is no evidence to support this, and my empirical personal view is that interspinous approaches to central disc prolapse are potentially very dangerous, and I think that's something that needs further discussion. So, in summary, this pathway, I'm afraid, lives down to my expectations. It's more clothes for the emperor's very extensive wardrobe. It's not clear who or what the pathway is supposed to be addressing. It is composed of largely meaningless steps which attempt to create certainty where there is none. And failing to acknowledge the deficiencies in our knowledge and understanding means that it's not only not particularly helpful, but potentially it's dangerous as well. And with that, Mr. Chairman, I rest my case.
Thank you very much, Tim. So I'll now open the debate to the floor. So if you could introduce yourself before you ask the question, and please start with your questions. Mike, first of all.
Thank you, gentlemen. Really good exposition. Tim, I share many of your sentiments, particularly as regards concerns around the Edinburgh paper, as you put it. And we had a letter which has also been published in The Lancet setting out those concerns. But as regards litigation, though, and a lot of my time these days is spent largely defending cases of CES. In terms of defence, if someone behaves in a reasonable manner, i.e. according to prescribed behaviours and standards that a responsible body of like-minded professionals would endorse, then there is a case for defence, okay? And really, I think, despite what I said initially, having a set of prescribed standards and also a way to go in terms of management will invariably allow that Bolam-type defence, if you like. And I think in some ways that's where we are with this. There is a lot of uncertainty, and you've highlighted it really well. The definition of what Cauda equina is this ephemeral sort of shadow, really, which we're all chasing. But really, it's the prescribed behaviours which will inevitably, provided people construct frameworks and various sort of SOPs that adhere to them, I think it will reduce litigation, and hopefully it will allow an easier defence of sometimes these very difficult cases where there is uncertainty as to what people should do. Thank you.
Tim, do you want to answer that?
Well, that would be my argument, is that you're creating a prescription which is correct when it actually isn't necessarily correct. It's a sort of best guess. So, for example, if you say that all surgical approaches are safe and actually interspinous approaches are causing problems, then it's the interspinous approaches. But if you've got if you've got a document that says in court, oh, this document says it's safe, then you're actually creating the situation where patients are being exposed to harm, but they won't successfully litigate because there's a document that says it's acceptable.
Yeah. Tim, I think one of the things that has come out from, and the example that Mike showed of a patient with numb genitals but had executive function of the bladder, okay? But really, one thing that has come out from that paper is it should inform the risk discussion with a patient who arguably may be, and I don't believe in it, but it's so embedded in literature, that early Cauda equina syndrome impending. But when you're faced with a 27% complication rate, I think that's to some extent what this is allied with the pathway, which requires people to adhere to some of those standards, Tim.
Right, second question, thanks very much.
Before I ask the question, Mr. Chairman, do you mind reminding us what the actual question for the debate topic was?
The question is, this House believes that the GIRFT pathway for Cauda equina syndrome is the best way to improve patient care and reduce litigation in the NHS.
So I believe from that question that best is the most important part of that question. Both of the talks that we had, and even Mr. Grevitt's comments just now, were about improvement. Improvement is important, and we can see that it does improve. But I don't believe that either side talked about what the best way was. So something can be good, but is it the best? And I think that might be what you were arguing about, Mr. Chairman. So maybe we should probably focus on whether it's best. I know that's slightly different, but as a purist for debate, I think that's the point of why we're here, isn't it?
Thank you.
I didn't have best in my title, I have to be honest, because it wasn't the title.
And it wasn't in your presentation.
I had to check the email this morning because it's not in the programme. But, you know, the question, for me, the debate was, will it improve patient care and reduce litigation? That's what the question was. We can argue to the gap. I mean, we had 60 people arguing till the cows come home of what we thought would improve patient care. Just one thing, Tim, the interspinous approach, really good example, okay? The reason why that guidance is in there is because we were also able to review litigation cases. And there was an expert who is claiming that to do not to do an interspinous approach is negligent. Mm-hmm. So that is what's out there. And that's the problem we've got. So you believe, not unreasonably, that it's a dangerous approach. And there are experts out there saying, when in fact there's evidence for none of that. So put in a generic comment of use what you're familiar to do, be aware of these approaches, but there isn't a particular approach that we think is protective of the surgeon undertaking the case. We don't know on that front, so hence that broad statement.
We're not supposed to be protecting the surgeon, we're supposed to be protecting the patient.
Yes, and we are protecting the patient because, you know, we also know that if a patient gets told when they've had not a fantastic outcome with this terrible disabling condition, and that someone tells them, well, you should have had it done a different way, that causes harm for years, psychologically.
Ashley. Oh, John's first. John.
Thanks, guys. John Leach. Tim, I think the guideline's not trying to deal in absolutes or absolute truth. And I think an important point is we're trying to look outside the sphere of our surgical intervention. You made a good point that once we get the patients, we're doing all right. But it's been talked about in myelopathy as well. We need to look outside our narrow sphere. And what the guideline does is an end-to-end patient pathway. And we do know what some of the problems are from litigation. You know, there is no evidence that one way of doing the surgery is worse than another. And that is not the focus of a lot of litigation. It's the fact that a patient presents to a non-spinal clinician who has no idea what the diagnosis is. It's the fact that patients still get sent away from an emergency department with clear evidence of suspected Cauda equina. It's the fact that local hospitals will not do emergency scans. So the guideline doesn't address whether a scan within 1 hour or 4 hours is better or how you should do the surgery, but we must give some guidance to stop the terrible harm being caused by clinical errors, and that's why I would support it.
Thanks, John. Comment, Tim?
Well, I mean, I think that's my point about exactly what is it aimed at. Is it aimed at getting early scans and recognition of symptoms, in which case it needs to be aimed at where the problem is. And, you know, I think that is my point. And then when it comes down to litigation, you can say that it costs a lot in claims, but unless you analyse, a claim doesn't mean there's been something done wrong. So you have to be very clear about that. They're two different things. Whether a case is settled or not doesn't mean that negligence is proven. So I think there is such a deficit of information. It amounts to exactly what I suggested, and that is that these guidelines are trying to create certainty where we don't have the information to be that certain.
But Tim, you know, a really good example in the pathway, again, I can tell you one of the commonest causes of litigation, as in the claimant, is all about deterioration. So, you know, if you are deteriorating, that may have some influence on your surgical timing. It is quite clear, and really commonly when we go through these claims, because of the transfer that's occurring, okay, there is not a time-stamped neurological examination on the patient of their signs or symptoms. When they've been, and the first one was, you know, at 10 o'clock on the Friday. By the mucking around that goes on the next day, they're then going to theatres in the centre they've been transferred to, and no one knows whether they have exactly the same as when they presented or when they got worse. So you criticise the fact that it says something that, yes, I agree, it should be obvious. But unfortunately, we're not doing the obvious, the simplistic things that we should be doing. The interpretation of bladder scan, great paper. The fact that we even have it as an adjunct, it's obviously come by. We don't know, but people are misinterpreting evidence-based. So if you're not sure, you can go and look at this, and you can do simple, basic things and get them right.
Ashley.
I'm going to keep it fair and have a question for both. So quick question for Mike. Can you just confirm that NHS England will review the pathway at a specific date or on the availability of new evidence?
So I can absolutely confirm that, as with all the pathways. So it should have a review date on it, and I think it's 1 year after inception. One of the timeframes that had to be agreed was that the concept of, and you could argue, look, we've been trying to get this for years, the radiologists, to get them to sort of say, yes, we agree with this, they wanted units to be given at least till June 2024 before getting MR, on site 24 hours. So that's the target. And I would suggest that we need to maybe review that around that time. And it's not going to be me doing it. I'm not going to keep doing this. This is something that's going to need to be reviewed regularly with literature, with groups. But I tell you what, I mean, it was hard, wasn't it? We all, the people that were on it, it was not easy. But I think it's a fantastic step forwards.
Yeah. And 2 quick questions for Tim. Would you feel happier, Tim, if there were recommendations for research in the document that recognise the uncertainty that we have around this? That's one question. And the second is, I share your concerns about post-operative worsening from cauda equina surgery. Do you think that consultants should be delivering cauda equina surgery?
Well, for me, the issue is interspinous approaches, because I think that's dangerous, whoever you are. Now, I accept that other people don't think that, and that's why I think a debate and some consideration needs to be given, and I guess that's further research. Yeah, I think recognising the deficiencies is also honest for patients. I mean, I'm stunned by the complication rate, and actually, the case Mike showed, where the patient still had control of his bladder in a condition that we know can spontaneously resolve, and surgery has a 12% chance of making you worse, I don't think it is that clear-cut. So, I think there is more of a problem here than we are acknowledging. And we need far more knowledge, and we need good quality studies rather than lots of poor quality ones. And we have to address the questions. And I just think it's not focused enough. If the problem is it not being recognised and people not requesting and providing scans, then that needs to be targeted. Because people who don't know about the problem aren't going to go look up the guidance on the problem they don't know about, are they?
I mean, if I can add on that, but there are problems. If you speak, we've got lots of people in the room that aren't surgeons who have to see these patients, and they need some guidance as to what to do with them. And if we're all saying different things, then the stuff that we might all agree with in secondary care, they're not doing. So that's one part of the aims of this. And we've been trying to do that for some time.
Mike McCarthy, Cardiff. I believe the pathway will improve patient care and outcomes, but I believe that in the short term, the litigation will go sky high, because you've suddenly got some rules and guidelines in place which cannot all be adhered to or followed. What do you think about that?
That's the point I thought Tim was going to make. So, Richard Mannion, who was on the group, said, look, just by putting, you need to get a scan within this period of time, and will be in itself a way of looking at things. Now, what was also clear, remember this has also gone through barristers and solicitors, and claimant barristers and solicitors particularly, and their view was it cleared up for them areas of contention, and I'm sure in my experience also they may find other areas that they want to work on, but they felt it provided clarity for standards. Now, you may well be right in the short term the litigation goes right, and as I said, I thought that's what Tim would say.
Next question at the back.
I think this one first.
Oh, sorry. Yeah.
Joanna Surtees from NHS Highland. I'm a spinal physio, but I've spent the last 4 years working in primary care. With any pathway that's really relying on subjective findings in the first instance, right at the start of the pathway, it's always problematic. Do you think there's enough in the pathway to really educate those in primary care to ask the right questions?
I'm going to say yes.
Yeah. I potentially say in practice that for me is the main problem out in primary care, that there is the lack of this specific drumming down to the details of the questions, of asking the right questions.
We would love it. It's like what we've heard with cervical myelopathy. We'd like to be able to gun it down to one question if we could. We need better evidence, but as things change and we get the better evidence, there's lots of change in the last 5 years. That's what's also great about it, is it can be updated to reflect that. And pathways are not a new thing, you know. We have them in TIs, at strokes. You couldn't get a CT scan for love nor money with someone with a head injury back when I started, and now it's all part of a pathway, exactly what happens.
And I think we'd all really like to have the one question that we need to ask that tells you you've got Cauda equina syndrome, and naively, that's where I started in all of this with David Bell. I thought the question about bladder function would reveal all. It's just as good as tossing a coin. It's a spectrum, and in that spectrum is a whole lot of psychosocial mess, and that's why it's difficult. Next at the back.
Thanks. Joshua George from Manchester. So there's a lot of literature out there on CS, and every SPNS, every BAS meeting there's tons of papers presented on CS. Yet when the pathway was being framed, it was clear that for some of the critical steps, there was really very little evidence base, and the steps were framed after, I suppose, so-called expert opinion and consensus. So, Mike, could you crystallize what are the research questions which have been raised by this pathway so that version 2 can be better? I know we've heard a few of them, but perhaps you could just encapsulate in a few words.
So let's just work through it as a pathway. So presentation, the duration of symptoms that have occurred prior to presentation, does that affect outcome if you look at the other end? So if you've had these symptoms, I could exaggerate, for 6 months, are you going to impact upon those because they were deteriorated at the time? So duration of symptoms, the reliability of a symptom. So asking someone whether they have back pain versus their saddle areas. Now I know there's some papers that looked at how useful those are. We need to try and really hone it down. You know, a bit like when you're trying to get on a sat nav to the right place, you can use what 3 words. So that aspect of it. Does getting an MRI quicker improve patient outcome? It's all about patients. That's for me is important. The role of the bladder scan, I think we're getting there. We'll get more data, so we do need a whole load more data to know. You know, does the bladder? Could we use the bladder scan? Could we use the bladder scan in a way that allows us to triage patients in and out of things? And then in terms of its timing of surgery, should we be doing this surgery, you know, as the pathway says, pretty much only secondary to immediately life-threatening problems, or can we leave it for 24 hours? Is it safer to do so? And then I think in the post-operative aspect of things is I just have a real feeling, because it was fascinating with the post-operative group that was there, I have a real feeling that if we can help out with these services that are really strained, because I happen to put the patient in the right direction of psychological support, in the right direction for the management of their sexual dysfunction, which, just for the men in the room, Viagra works in women too. I had no idea. And then there was no debate about that. So I think there's lots and lots of questions. And the other thing with that is of course, by having the pathway, things like the National Institute of Health Research will fund those things. So Ashley's point earlier, I do think we need to publish what we think we could do better, just as a plan, not actually undertake it, and then try and feed that into the pathway in the longer term.
Right, we've got time for one more question, then we'll wrap up with a vote. So the last question, thank you.
Michelle Angus from Salford. So I generally think the pathway is a great idea, but my question is, Mike, I work in ED, and if I follow the letter of the pathway to the letter of the law, we know that this condition can be variable. If I have a patient that comes with a 15-day static history, I'm therefore sending them back to primary care to be investigated there if I follow this pathway. Am I delaying what could be potentially a difficult condition for that patient? Are we taking away that clinical reasoning of 14 days, 15 days, that ability of clinicians to make a decision?
Yeah, I don't. So, it's a great example. 15 days, right? They've come to you. They've had at least 15 days of static symptoms, and they started bang. I don't think the pathway is saying do not investigate that patient. okay? It is saying you don't need to send them in as an emergency. Now, do I know, are we going to suddenly be rushed with loads of patients who'd had, 21 days of static symptoms and should have been operated on there? And then I would argue that the majority of the spinal surgeons in our community would say, look, certainly doesn't need to be done that day because we've been going on 3 weeks and it hasn't got worse. But we'll see.
Tim, do you want a final say?
I don't think so.
Okay. In that case, he's confident. We'll go to the vote. So I'd just like you to put your hands up if you still support the pathway. Now I want you to be scrupulously honest and say, those of you who supported the pathway with the first vote, have you changed your mind? Are there any people that have been persuaded?
I thought you did really well, Tim.
Wow. One. Anybody been persuaded the other way?
No, so we haven't changed the audience. Can I just say one thing, though, that I thought was brilliant about today, is we need to debate these things, okay? And to Tim's credit, and mine, I will say, we got asked to do this at very short notice. And I just think if we're having these policies and pathways coming out, they have to be discussed in the national meetings, just like we have done, because people need to be given the opportunity to criticise, etc. And most importantly, I've learnt a lot from Tim's analysis of everything. So when I work on reviewing this, I will try and incorporate those things to make it clearer. And that's all that the group tried to do.
Yeah, that's what meetings are about. It's about feeling free to express opinions and without judgment, and we need to encourage everyone to feel liberated to say what they think and feel.
I've got to wrap this up now, so I'd just like to give a present to each of the speakers for the work they've done, both preparing the pathway and also criticising it so thoroughly. Thank you very much, everyone.